another drug that's also in this similar space of a multiply relapsed hairy cell leukemia, although not approved by the FDA, is a BRAF inhibitor, which we talked about earlier, and obviously the almost near universal presence of the mutation in itself and the possible implication of pathogenesis. So how do we use the vemurafenib kind of in this relapsed refractory setting? I know I would participate in that, saving that you're part of the U.S. multicenter study, and a similar study happened in Italy as well, led by Dr. Tiazzi and Follini, and also as also alluded earlier, combination rituximab with the vemurafenib in the relapse setting, which appears to increase the rate of a CR in those patients. Perhaps Dr. Saban, that you can share some of the experience with the vemurafenib in this relapsed refractory population.
Okay. I participated in Jay's study in the US. We used a dose of vemurafenib that was very high. It was the melanoma dose. If I remember correctly, it was 960 milligrams twice a day. And that was a big dose, and people had a lot of side effects. They didn't feel very well on the drug. They got skin rashes, asthenia, arthralgias. If they had a hint of skin cancer before the study, they developed invasive skin cancer, keratoacanthomas. Some patients even had uveitis. But the drug was active. Most of the responses were partial rather than complete, but it took protracted therapy, probably 3 to 6 months of oral therapy before they achieved their maximum responses. Since the completion of that study, I've decreased the dose to 240 milligrams twice a day, and the side effects are much more manageable. In fact, most people have minor skin changes, minor asthenia, minor arthralgias, and tolerate it well. The duration of therapy isn't really known. So if the patients tolerate the therapy, I often do it indefinitely. In terms of what private practitioners will want to know is, did you get it approved? I haven't had any kickback yet, probably because hairy cell leukemia in this subgroup of patients with relapsed and refractory disease is a very small number of patients. So if it was a common disease like melanoma, maybe, or another disease, maybe I get more kickback, but I haven't had kickback in hairy cell leukemia. Every time I've prescribed it, it has been approved. I usually use it as a single agent, but there is data that you can combine it with an anti-B cell agent, and you'll improve the duration and depth of response. And I only have one single patient who achieved a partial response on dabrafenib. He's a young man, but his blood counts weren't still satisfactory. So I added trametinib. And interestingly, he actually achieved a complete response, didn't have an increase in side effects. And he's been on this combination probably for 6 months plus now, whereas before it was a partial response, now it's a complete response. You could argue that if he had received the dabrafenib longer, perhaps he would have got to the promised land, but I don't think so. I think it was the MEK inhibitor that changed things for this particular patient. And mechanistically, it makes sense that you're going to escape through MEK pathways. My experience with a much reduced dose from what that is published, i.e. 240 twice a day, is that it's well tolerated and achieves the responses.
I do agree that the combinations probably would be more effective in terms of producing responses more rapidly, because we know this from the rest of oncology practice that whenever we give a single agent, you get resistant pathways activated. So I have experience with dabrafenib plus trametinib, and the several patients that I've treated have had excellent responses. They do get fevers. Some patients, when you give this combination, particularly dabrafenib, get fevers, and in one of my patients, it was intolerable. So, but in general, is extremely well tolerated, and there are no skin problems with the combination. And also in terms of CD20 antibodies, personally, I would use vemurafenib in combination, again, because it does produce deeper responses and potentially of longer duration. And I'm not sure about indefinite therapy with a expensive oral agent, although we do this in every other hematological malignancy.
This remains the question. I think that some of the future the clinical research, hopefully we can get some enlightenment there from the several studies that's ongoing. Any of you guys have used ibrutinib, and then do you see a role in this either in the relapsed refractory hairy cell leukemia?
Yes, I'm part of the NCI CTEP study that's led by the Ohio State group, and we've used it in several patients. And it is active. It's rarely produce complete responses, but it does improve counts and does provide non-toxic generally strategy. And the patients we have used, obviously we didn't have many other options. In variants, I've had a couple of patients who have had very good responses. Again, not complete responses, but normalization of counts and improved quality of life. So it's an active drug. Clearly, the fortunate thing or unfortunate thing is now we have so many good and effective strategies for hairy cell that it becomes difficult to actually even conduct these studies. The ibrutinib study has taken about 4 or 5 years, but it does provide us with an alternative strategy for some patients and particularly for variants.